Hey, everybody. Welcome to Leading Rural Healthcare, where we're having conversations beyond the margin, where every other week we'll bring you real rural healthcare leaders with real challenges, making real impact in their communities. I'm your host, Brendan Hurley, and today I'm with Todd Ahrens with Hannibal Regional Healthcare System. Todd joined Hannibal System as general counsel and became president and CEO in 2012. He's led the health center through growth and change, as I'm sure he'll expound on, and I'm excited to hear what's happening around healthcare in Northeast Missouri. Welcome to Leading Rural Healthcare, Todd.
Thanks, Brendan. Excited to be here.
So, why don't you just start? Tell us a little bit about you. I mean, it's you came from Hannibal. Give us your background about the community, and then, of course, yourself.
Yeah, happy to do so, Brendan. I actually grew up in Hannibal. I'm the son of a lawyer and judge and a teacher that were both from Hannibal. Went to high school and were educated in Hannibal. Was born during my father's last year of law school. So when he came back to practice in the fall of the next year, I came with him. I guess I don't remember that, of course, Dad practiced law in Hannibal. I followed in his footsteps, became a lawyer as well. Actually practiced in the firm that he was with. At that point, he was an appellate court judge, so he wasn't in the firm as well. But came back to Hannibal and joined the firm. Enjoyed practicing law for about 10 years. Kind of what changed my career path was when I was elected to the hospital board of directors in early 2001. And, that kind of set me up on this path, I think. I spent a few years on the board, at which point the corporate counsel position for the firm opened up because our general counsel at the time passed away. And so the CEO at the time looked at me and said, hey, you're on the board. If you want to do the corporate work from our firm or from your firm, I'll be happy to let you do that. And I'm, smart enough to give up a volunteer job for a paying job. So I started doing that legal work, and really, it kind of matured into being the first in-house counsel for Hannibal Regional Healthcare System when I, left my practice and joined the hospital as its only in-house attorney in December of 2006. And did that work until the CEO that hired me retired, and put my name in to be the next CEO, and was lucky enough to get that appointment and started in October 1st of 2012. So I've been doing this a long time. I don't know if that'll make my experience and thoughts helpful to your viewers or not, but I certainly have a lot. Hannibal's a great community. It's a community of about 17,000 folks. Our healthcare system has the one hospital that's in Hannibal, but then we have clinics in 14 communities throughout Northeast Missouri. So we have a pretty broad reach. Some of those clinics are upwards of 100 miles away, including probably the furthest one from Hannibal being a clinic in Chillicothe, Missouri. That's a little bit about me and my background, the healthcare system. Hannibal's known as the boyhood home of Mark Twain, so that's our claim to fame. We wear it on our shirt sleeve. We have a lot of fun in the community with that connection. But other than your viewers maybe wanting to come up and check out the Mark Twain size, we probably don't need to go into too much detail there. But that's kind of a little bit about me, Brendan.
Yeah, it's an interesting. Well, I'd love to know. I mean, just aside from thanks for sharing, but of course, aside from going to law school, what made you decide to go to law school outside of it just being in your blood? What led to that decision? Then I'd kind of get into you kind of shared being on the board of directors and then leading into what got you into healthcare, but what got you into to law?
Yeah, really, as I was going through undergrad, I really thought I wanted to be a physician, a doctor of some sort. And you sent me some questions to kind of think through how I'd answer them. And one of them was, what didn't help me get to where I'm at in my career. And, the funny answer to that is, well, college physics and college calculus. I wasn't cut out to succeed in those areas. And so, at that point, I switched and the biology degree that I received became more about ecology and animals and sort of the the other side of biology. And at that point, I'm like, well, what am I going to do with this biology degree? And so certainly, that's in the 90s. There was a lot of talk about environmental law and the things that were
Yeah.
going on in the world then. So, I quickly made a decision, especially with the help of my dad as a lawyer at the time and later a judge, to think through, hey, tell me about what a career in law looks like. And so, that's kind of what got me started. And at least from my personal and family perspective, it panned out very, very well.
Yeah. Yeah. Well, it can obviously, you can do a lot there, right? Having that background, I've heard, is the ticket to being able to do a lot of other things you might not, even if it's adjacent to law, right? So, I mean, having that legal background, especially what I would call credible background, right? 10 years before even really coming on to be general counsel, but what prepared you most after the leap from general counsel to CEO to lead a health system and what didn't?
Yeah. Brendan, I'd say, two things were critical. The first was that, 5 or so years that I served on the board, really got acclimated to the issues in healthcare and how a board functions, strategic planning, healthcare finances, which are different than my law practice finances or my household finances. That was all very helpful. I would say from, an educational perspective, a law degree, I think, really gets people thinking analytically. And so, those analytical capabilities, I think, were very helpful to me in segueing my career from, more of a legal practice and lawyer career to one in healthcare and healthcare administration. But it's always interesting. I've see my colleagues or have gotten masters in healthcare administration and masters in business administration. I don't have any of that. So, maybe I always feel a little bit intimidated by some of these more classically trained CEOs and healthcare executives that took a more traditional path. But when we talk about risk or whatever, I can certainly hold my own at that point.
Right. Well, there's no shortage of it, right? As I'm sure you could tell us about. I mean, give us more specifically how it's shaped the way you approach that risk. I mean, governance and even just decision making as a CEO. I would say, I'd caveat that with a lot of your peers have come up the same way. Some have gone knew they were going to get masters in healthcare administration. Some were clinicians, right? And so I think your background is extremely unique. But tell me how that helps you approach that risk and the strategy.
Yeah. So, from a risk perspective, I think it's probably both a curse and a blessing, right? And I always kind of use an example, when I was the lawyer, we were working on an issue, and as the lawyer, I'm wanting the organization to avoid risk, right?
Right.
Don't take on any unnecessary risk. So we had an HR issue that had a fair amount of risk attached to it. And, so HR and I were aligned and we're trying to convince the CEO at the time, hey, you don't need to do this. I mean, what's the upside here? And of course he came over the top, said, hey, I'm doing this. And of course, I report to him. So if he hears my objection and decides he's going to do it anyway, I've got to get out of jail free card, right? But as I moved into the CEO role, we take risk every day, right? I mean, I'm probably taking risk sitting here and talking to you right now. And so one of the things I have to weigh is, I'm risk adverse as a lawyer by training, but I'm in a job where we've got to think about taking risk all the time. And so what I've seen for me personally is I'm much more willing to take risk on now as a CEO than I was as general counsel. And I think that's important, and I'm sure we'll talk about it later. You asked about governance. Every board I've ever been on, if that board has a standing governance committee, I end up on it. I think these people think I love looking at policies and bylaws and all these things, which I do a little bit, right? But I think lawyers by training just have you don't get a law degree if you're not capable of providing insight that's helpful to any governance committee. So, I think I told you before we went on air, I was talking to my lawyer, my general counsel, about some legal issues, and that brings up the role of governance and a governance committee. And so, I think I'm always using those legal skills to think through those issues, bylaws,
Yeah.
policies, D&O insurance, or the risks that my board members take on, or things of that nature. So certainly, from a governance perspective, the legal background helps. And decision making, I think we kind of covered it. It's analytics. I personally, I'm not trying to brag, but I think I can think through a question in the analytically and get to the good result uh, very effectively with that training. And so I would say that, to lawyers out there that are looking at, career moves, you know, just, law degree 101 makes you probably someone that's good at making decisions. And so that's been very helpful to me.
Yeah. Well, I can only imagine the number of contracts you enter into, how important it is that those contracts are favorable to you, right? I mean, we start talking about payers and some of the things that I deal with as a benefits professional on our side. I can only imagine how that comes into play. I would be curious, though, still sticking on this subject. Would you say you've been more aggressive the more years you've been in the role, or has your risk tolerance more or less stayed the same? You've just approached it differently, knowing the responsibilities you now have as a CEO to have to take those risks.
Yeah, I would say I definitely take more risk now in year 14 than I did in year one. And as I reflect upon, that time 13 plus years ago, I would say part of it is moving away from that legal role, right? Um, it's just part of being in a different role, right? I can't
Right.
sit there and not take on risk and continue to do from my organization's perspective what we need to do to be successful. And so I think that's a big part of why I take on more risk now than I did back in the early days of my tenure as CEO. But I think the other thing is the healthcare climate, which I'm sure we'll talk about, kind of necessitates that, right?
Right.
My personal perspective could be wrong, but my perspective is if our organization doesn't continue to grow, build more scale and take some of those risks to do what we need to do to, maintain our sustainability as a healthcare system, that then we'll be left with no choice but, looking for some partner to join with us to take us through that. And I'm not saying that's bad, but right now, my personal opinion, the opinion of my leadership team, and certainly the opinion of my board is we're of the highest value to our community and the patients and families we serve if we're independent
Right.
and making decisions about what healthcare we want to provide at any specific location in Hannibal or in that community.
Yeah.
And so I just think inherently we have to take more risk right now.
Right. Well, I'd love to parlay that and understand for all of the others listening out there that are leading independent systems, what are the crucial reasons you guys feel that way? That you feel that way as an organization? Again, some systems partner, you said, right? It's not a bad thing; it happens. But what is it about being independent outside of the inherent obvious nature of being independent? Do you feel like caters to your population, allows you to deliver the best care you can in your area, right? Among other things.
Well, yeah, let me take a crack at that, and you can follow up with me if you don't think you get the answer you would have expected. Um, I really think it's about our mission and our vision. As a nonprofit entity, we make decisions every day that don't necessarily impact the bottom line. They're not going to drive profitability, may not drive significant revenue, may not drive any revenue. I've got a project right now I'm working on where that is very true. And so, when we look at why we're doing that project, it's super important to the community that it's involved in. And if I'm part of a multi-hospital system that is looking at that and thinks, well, that's not going to drive the bottom line. There's a X million-dollar cost to doing it. We're not going to do it.
Right.
And so at the end of the day, then I think for that community, then those folks aren't going to be able to get that care locally, which means they may not get that care, or they have the burden of a burden to their family and to their employment and everything else in driving 100 miles to get that care somewhere else. And to me, it's sort of like the Medicaid expansion discussion, right? Without access to that care, most of the time that care just doesn't happen. And so, we're never going to meet a mission that's based in health if people aren't getting the care they need. So to me, that's why it's important. I certainly don't want, my colleague friends at the big systems, thinking that this is anti-big system, because it has nothing to do with that at all. When you have hospitals and providers and facilities throughout the state, you make different decisions about the healthcare you provide in those various communities than we make when we own it, so to speak. Right. So that, to me, that's why it's important.
Well, to align with your mission, right? I mean, to align with that mission that you have and to do it at the highest level, partnership might make sense for you at some point, for some systems, right? To what's going to allow me to carry out this mission the most effectively, and being independent obviously aligns most well. I mean, after a decade, of being CEO, let's take a step back from risk and take a step back from just talking about your independent status. How has the job changed? I mean, how has the job of CEO changed, and how have you had to adapt as a leader in the environment that we're in, which could be a loaded question?
Yeah, no, it is a loaded question. I figured you'd ask this, so I've kind of thought through it a little bit. Brendan, I think when I started as CEO in 2012, the job was very hospital centric. And part of that was, kind of how our system had been doing business for the few years before that. I think some of that was just the healthcare industry in general. And I think as we've seen organizations employ more physicians and other providers, we've gone from the point of being hospital centric to really system centric. And so for me personally, that's made me think differently about my role as the chief executive over a system that now has those, clinics in those 14 communities that I talked about. Our last fiscal year, we saw about 300,000 visits to those clinics. Well, that makes the organization I'm leading now completely different than the organization I was leading then, right? And so, the other big change I would say has come, well, really two. One has come from this younger generation of people that we're leading. And we've seen that for a while with nurses and other folks that can get through their education and training more quickly than a physician. But now we're seeing that in those physicians too. They're looking for a different lifestyle. They have different perspectives on, their career and how that aligns with their family. And I would say, leading those folks now is just a different challenge. It's not a bad challenge. It's just completely different than it was when I started in 2012. And, physicians, the calling was you're available all the time, and you come in and take call all the time, and you treat your patient wherever they are all the time. And that just doesn't exist anymore. And so that's changed our operations. I also think, and I was slow to get to the advocacy boat, especially from a legislative perspective. Yeah. But my job has changed a lot in the last 3 years in the need to be working more closely with our elected officials. And so those are the three main changes. But, kind of tangentially, one of the things I feel, we employ probably 1,750 folks. Those aren't all full-time employees, but that's the number of paychecks we cut on an every other week basis. And when you lead that many people, it's tough to not, in my case, think of that as a paternal responsibility, right? Um,
Mm,
Paternally, I need them to be sick, think of this as a calling and know that they're going to be taken care of from a work perspective, both monetarily and benefits and those sorts of things. And I don't think I had that paternal instinct when I started in 2012. So to me, that has
interesting.
changed a little bit. Um, and you know, I mean, it certainly adds to the stress a little bit because I care about those people. But on top of that, I think about these people that work for us that are paid a fair wage, a good wage. Um, these folks are also driving economic development in all the communities where they live and work. And so, um, it seems that the healthcare entity has really grown in its community and interpersonal relationship responsibility as we've
Yeah.
gone through our challenges and grown and continue to provide what's so important to people in the care we provide. So I don't know if that's a good answer to your question, but
No.
those are things that I think about now more. I think about more now than I thought about 13 or 14 years ago.
Yeah. Well, it's certainly evolved in a number of different ways. Your mission maybe hasn't, but the way you've had to adapt, it certainly has. I want to kind of harken back to one thing you said that, you know, even mid levels physicians, they're looking for something different as their environment changes, right? For many of whom, 30 years ago could have owned their own practices, and some still do, depending on the discipline, the specialty. But you'd said something that kind of perked me up, which was that they're looking for something different too. So do you feel attracting that kind of talent to a rural area? I don't want to say has it become easier, but is there a different enticement that you're seeing or a different strategy that you guys have found effective to attracting talent to a rural area? I know we're going to get to the residency program, right? And you could tie that in, but I'm just curious if you're seeing that or if that's why you made that comment.
Certainly we've had successes. We employ probably almost 100 physicians throughout the healthcare system and maybe another 50 mid-levels, mostly nurse practitioners, but some physician assistants and other non-physician providers. You know, I think the days where younger physicians only are looking to go to the larger cities, um, that's just not true anymore. And so we've benefited from that movement. And I don't know that I can really tell you why.
Yeah.
I think part of it is, certainly physicians do not want the headaches. In my experience, they do not want the headaches of running their own practice, getting bills paid, dealing with HR issues, insurance issues, whatever the case may be. You know, the method my organization has employed that we think is somewhat attractive to physicians is, and I tell them this when I interview. I mean, I try to interview every candidate that's looking for employment here. Um, I'm not a physician. I'm not a clinician. It'd be foolish for me to jump in and say, clinically, you're making a mistake. And so, I tell them within reason, when you start here, you're going to have almost the same autonomy you would have if you're in your own private practice, but you're going to be able to unload all those things you don't want in private practice on the resources we can bring to the cause. And so, and I think some of them look at me like, oh, he's full of it. There's no way, the CEO is not going to be down in my office, talking about why I need to take an extra 5 patients a day or those sorts of things. And I really don't. I have never done that. I don't want to do that. And maybe, we certainly don't just let them have carte blanche. But at the end of the day, we spend a ton of money recruiting them here. If they need a $10,000 scope to better do their job, in the greater scheme of things, I find a way to come up with the 10,000 bucks.
Right.
And so, I think that's been attractive. The other thing that I think has really helped us is we've recruited some, physicians, that are just now coming out of training. Well, they've got buddies that are also looking for jobs that might be in, in a longer, might be doing a fellowship or, a year behind them in school or whatever. And so, we get them up here and we prove to them that we're not going
Be the
to,
poster child.
yeah.
Yeah.
And so that has worked. And because those physicians now their socialization isn't in the medical staff lounge when they're talking about patients, it's at their kid's soccer game,
Right.
or these other things that they're doing that's different than what those more senior and mature physicians were doing when I started. So I think some of those things are helpful, but it's all about culture. And
Yeah.
I think all of the organizations, the colleagues I have as CEOs, they do a great job of that culture. But I think it's benefited all of us.
Yeah. Well, tell me a little bit. We alluded to it, but you recently received accreditation for the new internal medicine residency that's going to start or slated to start sometime next year. Tell me about the decision to begin that program. And starting a residency program, was it the right move for Hannibal Regional, or why it was, I should say, and then why now?
Yeah, so certainly we think this was a very smart decision, but kind of gets back to the risk discussion we just had, right? I mean, would have been easy just to say no, and leave all that risk, off the table, so to speak. But when you think about the growth we've had, adding those clinics, employing more providers, seeing our hospital get busier, we decided that one of the several ways we thought we could have better access to a pipeline of physicians was by having the residency program where they have a daily touch point with our healthcare system and our leadership and our board and the other physicians and the patients we serve, on a going forward basis. And we kind of tried it out because right now we bring third and fourth year medical students in from the University of Missouri, from A.T. Still University in Kirksville, and they'll do some of their medical school rotations here. And we saw the interest that generated in being connected to our healthcare system. And so the residency program was really just kind of the next logical step in doing
Organic.
that.
Yeah.
And so, we thought about, well, should it be family practice or radiology or anesthesia, whatever, specialty you want to come up with. And one of the challenges we've had, somewhat on the clinic side is, finding primary care docs that want to take care of our patients in a clinic setting. The other thing is hospitalists. We're seeing a lot of churn in employment there, and the need for locums to cover shifts and those sorts of things. And so an internal medicine residency can kind of kill two birds with one stone, right? We can find clinic docs that, want to be internal medicine specialists, but don't want to have a hospital practice. Alternatively, we need some IM specialists to come in and pull hospitalist shifts and take care of our hospitalized patients. So that was kind of the strategic decision there. We were benefited in a large way from a $750,000 grant from HRSA to help kind of take the cost in getting that program up and going off the table, or at least partially off the table. It probably cost more than $750,000 to do that, but when you're not having to pay full boat for that cost, then it makes it more attractive. And so, yeah, we're about a year away from matching physicians into that residency program for a July 2027 start. But I think it's going to be hugely successful for us.
Yeah, well, I can't wait to hear how it pans out, and I'm sure it will be. You've talked about how Hannibal Regional has grown to serve other communities with the clinics, and your footprint has just grown to serve the communities across Northeast Missouri. What does it take to lead a true regional health system in a largely rural footprint?
Well, I think it has you have to have a connection to the ruralness, right? It's a different beast. I've got a clinic in Paris, Missouri. Paris is the county seat of Monroe County, but in the town of Paris, if there's 2,500 people, I'm probably guessing high, right? So, you know, I think it benefits them when they get to know me. When I go to that clinic, I talk to the team and the professionals in that community that are, care so deeply about it. That connection is important. But the other thing is you got to understand what the community needs. And so when we do community health needs assessments or, have other interactions with, the local health departments or things of that nature, to really lead those communities and make sure we're making local decisions for the healthcare those communities need, we have to know those communities. And so to me, that's kind of the key. And obviously at 14 clinics throughout Northeast Missouri, some of those are an hour and a half or better away. I can't always do all of that. So it takes a team of leaders that can get out and have those relationships and make sure we're connecting at the community level, because that's going to be important to them. And so that's probably how we are most successful in taking that footprint and expanding it so much to make sure we're taking care of those communities. But at the end of the day, I want them, if they're in Paris or live adjacent to Paris, I want them to get their healthcare in Paris. I don't do that so they'll come to Hannibal. It may be that, Paris still has draws to Central Missouri. So maybe, we take care of them in the clinic setting and they go to a different provider for their specialty care. I don't care. I just want them well. I want them healthy. And, it's great if they can get that care from us, but, if they don't choose that, that's fine too. That's why we kind of bake into our vision that we want to guide people to better health. Sure, we'd love to be the provider of that health, but if they get it somewhere else, that works too.
I love to hear that, and I think the viewers outside of healthcare that would hear you say that as a hospital CEO, would go a long way. That it is baked into your mission, right? That it's not. While you'd love it, right? It's not critical that we just refer internally or we just use this as a referral chain in these communities. I mean, how do you balance being large enough to offer some of the advanced serve talking about referrals, right? I mean, from those communities to offer those advanced services while still staying grounded as a community-based organization, right? I mean, you'd mentioned earlier some services make money, some don't. I'm sure some lose money, right? But as long as they're part of the vision and being able to serve the communities you're in, there's got to be a decision process right there that you go through to say this is crucial.
Yeah, I would say, Brendan, to offer, you can't always take care of your community from a community-based perspective unless sometimes you have those advanced services. And so that's kind of where we look at things. We don't think we're getting bigger and that's the only way we can be better. But, say, let me give you an example. We started open heart surgery here at Hannibal Regional Hospital. It'll be 3 years in November. Okay. I'm not aware of any smaller community, any community of our size that offers open heart surgery. Okay. That wasn't necessarily to just offer that advanced service, right? And open heart surgery in and of itself isn't necessarily a huge profitability center, right? We did it though because we looked at the numbers and saw that there's 150 people a year from our area that until we open that have to leave the community for that care. And so say you drive 100 miles from Hannibal to get your bypass surgery, which is fine. And those other providers are good at providing high quality open heart surgery. But, usually it's a 4 or 5 day stay, right? That's a hardship. And so we try to look at it not just from an advanced service or a community-based service to one where what does our community expect within reason as to care that they should be able to get locally. And so that's how we thought through that. Then we pro forma it based on that expectation. and make a decision. If, if it's profitable, it's easy, right? If it's less than profitable, then you got to think about, well, does this square in our mission? And if so, can we, still make a bottom line taking care of that service that might not be profitable? So that's kind of how we think through whether it's, an advanced surgery versus community based. But at the end of the day, we're not trying to be a tertiary provider. We're really trying to take care of our local citizens um, in a way that lines up with their expectation of what they should be able to get done locally.
Yeah. Well, it's an investment, right? And it's an investment back in your community. We've talked a lot about values and mission statement, but I mean, you guys, you're forced to make investments all the time, which is increasingly difficult for rural systems, or can be. And in 2019, you guys made an investment in facilities, surgical technology, medical group expansion. Talking about risk again. What gave you the confidence to make that bet, and what did you learn from it?
Yeah, so I appreciate you asking that, Brendan. At that time, we had one office building for physicians here on the Hannibal campus, and it was full. So, like, I wanted to bring in, a new specialty or another physician in a specialty. We already had physicians. I had no room in the end. I was honestly converting closet space into offices to house additional physicians so that they could have an office and then space in the clinic to see their patients in the clinic setting. So we were kind of at an impasse. And so in a lot of ways, don't give me any credit for the decision. I just wasn't going to be able to hire any more physicians without more space. And further taking away from any credit you want to give me, it was a great interest rate climate to do that. So, we made a decision to sell some bonds, north or right around probably $40 million at a very attractive long-term interest rate, where we could kind of spread the cost of that decision going forward. Of course, we were in a good shape. We didn't have debt at the time, so it wasn't a tough decision to make. But we were just to the point where if we didn't do it, it wasn't going to happen. And so, we were going to be limited in what we think was the necessary successful strategy going forward. But, we did it wisely. The surgical technology, is something that we needed. Our hospital was 30 years old at the time. So the size of those surgical suites was well below standard at this point in time. So, are you going to attract a urologist that's going to come to a surgical suite that's a third of the size of most going suites? I mean, they were things we just had to do. And then we were smart on the medical group side of things. The costs were attractive, so we actually built extra capacity. So I've got capacity. We're now almost 6 or 7 years out from that decision. I still have capacity going forward for expansion opportunities. So space for the residency program, or work we're doing to join up with Culver Stockton to start a nursing program on site. All those things will help us. That extra space will help us going forward.
Yeah. I mean, it was good timing, right? I mean, you talk about all the reasons why it was maybe an easy decision, but for some, healthcare leaders who might be listening, capital investment, for them, or in rural and regional areas are tough, right? With tight margins and expectations that keep rising. So what might you tell, a CEO or other healthcare leader who feels stuck in feeling like they have to defer the investment that they need to accomplish their goals and their mission?
Yeah, well, and I think that CEO's got to think about, spending cash, borrowing cash, however you get to the funding of that capital improvement project is tough, right? But you really got to think about what's going to happen if I don't do it. And so that's what I thought about now. I had surgical suites that weren't going to be attractive to most surgeons coming out of school. Certainly couldn't accommodate, a Da Vinci robot or other things like that newly trained surgeons are being trained on. I had substandard ICU rooms. So I built new ICU patient rooms, which at the time was great because we were slow to open up the ICU. We just used that to house our COVID patients at the time so that they were segregated from other patients. The other thing is, and I hope, the rating agencies that rate my bonds aren't listening, but, that's the struggle, right? They want you to have, 300 days of cash to get the rating you want on your debt. And that's all well and good. I'd love to have 300 days of cash, but sometimes you got to take the risk on the rating agency side of things in order to have the facility and the ability to provide the services you want to provide on the patient care side of things. So that's one of those risks, right? And some of that's selling your board, right? Some of my colleagues have elected boards. They have, governmental entities where their boards are appointed for them. That's tough. And so you got to sit down and talk about, okay, we can do this. It's going to take this amount of our cash and get us to this point from a day's cash perspective. But if we don't do it, where are we going to be? I would think some of those organizations would want to think about, well, if that puts us to our only option is to partner with somebody, well, then, is that the end result you want? In a lot of cases that may be, but, we just have a different strategy right now up here. And when we think about independence like that.
Yeah. Well, I love it. I mean, it kind of ties into all of the things you're doing. I mean, I would love, if we had more time to spend time talking about how you manage. In fact, give me a little bit how you manage relationships. You alluded to the fact that many hospital CEOs, the makeup of their board is different for every situation and every depending on how they're owned, whether it's city owned, county owned, independent, nonprofit. But you've got to be educators, right? I mean, you have to be able to tell the story well, which is what, of course, any good CEO is able to do. But selling them on it is crucial. So, I guess taking a step back, what are some tips you have? Regardless of the type of relationship, if they're appointed, elected, et cetera, with just how have you managed the relationship with your board, and what are some best practices?
Yeah. Well, I think some of that is just, orienting them to healthcare. When I bring on new board members pretty much every year, just because of the churn that we have with, terms limiting. We have a self-appointed board, so they pick their own board members. They can serve three-year terms. And, we always think about it, this is not a Chamber of Commerce board or a YMCA board, right? I mean, people want to be on a hospital board because it's truly a way to serve their community in an area of healthcare that there's hard to find anything more important than that, right? So I spend it seems like an inordinate amount of time orienting new board members to their role and to healthcare finance. And then one of the things, a strategy that we've done is for our board portal and other educational resources, we are a member of the Governance Institute. And being a member of that, which is at a cost, but being a member of that entitles our board members to go, I'm pretty sure it's free of charge, to national conferences that talk about healthcare. And I think all we really have to pay for is how they get there and their hotel stay. And usually, like with a newer board member, I'll go with them. And so, we have time in between sessions or in the evenings when we go out to dinner to just talk about what they heard and how they can apply that to their work and their role as a board member. And then when we get them back, we ask them to talk to the board about what they heard and what are the national trends or the regional trends that they're hearing. And to me, that has helped them get acclimated to that role, which is different than any other board role they've taken on. Yeah. And so that's a big way. And then just, staying in constant communication with them. I try to not burden my board with, going to lots of dinners and those sorts of things, Because when I burden them, it's going to be on, making an important strategic decision, or, we're struggling with issues. So I really need your time and expertise in helping me think through from a governance or policy perspective, what's the best way to get through that. And so that has worked well. But at the end of the day, I think, the board going through a very specific process as they kind of name candidates and vet them. It needs to not be, it's just my time to serve on this board. It needs to be because they have an interest in really helping the organization with its governance goals.
Yeah. Well, I commend you. I mean, I'm sure, having a formalized process not only gets them ready, but it allows you, I mean, going with them to events, especially new board members that are new to healthcare, new to being on a board, perhaps, right? It can take, I'm sure, a lot of different forms, but you're able to establish a relationship too. They can ask you real questions, get to know the organization at a very deep level. And then to your point, you're not overburdening them until it's time to make a big decision as often as you can avoid it. So, I mean, taking a step back from that, I mean, prepping board members, I know you've served, this could be a great segue into the Missouri Hospital Association. I know you've served as chair and now sit on multiple state and national boards. Talk to me about kind of a two-part question, how MHA helps with the resources they might provide in any given perspective, but specifically around board governance. And then how important is it for CEOs to engage beyond their own organizations, right? You said early on, it took later in your career to get involved in legislation and get involved in advocacy boards. How has that helped you? And tell me kind of how you decided to make that decision to get involved.
Yeah, Brendan, I don't know that I know how, what I was thinking through that made me get to that decision point. But it was maybe, 4 or 5 years into my tenure where I started serving on boards. The MHA board was one. Their structure's set up in a way that, there are some at-large spots, but otherwise you're generally starting by being elected by your peers in your regional district within Missouri. And that's kind of how I got going there. But then served on, a lot of us on the nonprofit side get our malpractice insurance from a company known as Healthcare Services Group. And so served on that board as well. And so I think once you get involved in organizations like that, you almost immediately realize that these connections with your colleagues is going to be crucial in helping you be better at your job. And so I would encourage any CEO listening to this, if they're not involved in these things, the collegial relationships you develop will pan out and they will benefit you. I have colleagues that I text almost on a daily basis. Hey, I got this issue. What do you do to work through things like this? Or what have you done to fix this specific issue at your organization? Because you can't know everything in this role. And so I think that sort of networking is critical. And then, the thing I tell people that ask my opinion about this, so thank you, Brendan, for doing so. This job is a grind right now. We got a target on our backs, both at the state and federal levels from a political standpoint. It just, you sit there and you look at it and you think, how are we going to get through this? Right. And so, you got to keep your head on your shoulders, right? And you got to find a way to not think about the grind, think about, the quality of care you're providing or the other benefits that you're providing your communities where you serve. And so I find being involved with these other organizations is just a fun part of the job, right? I get to play golf, with a couple of these organizations, on the afternoon after a meeting's over or whatever. We go out to dinner and enjoy a drink or nice food. I'm in one organization where we met up in Minneapolis last year. So we got to go check out Prince's studio in Minneapolis. I mean, those sorts of things can keep you coming back, right? It's like being a golfer that is as bad as I am. I'm hacking all over the place, but I'll hit one good shot and it makes me want to keep coming back and playing golf. Well, the same deals here, right? You may be frustrated with what you're dealing with in the operational roles of your job, but hey, if I get to spend time with a friend next week, I can keep doing this. So
Yeah.
it's almost a burnout avoider if you want to think of it that way. So I would encourage any young CEO. We've got several new first time CEOs in hospitals throughout Missouri, and I'll use this as a mechanism. I'm happy to talk to anybody about how they can, get that life work balance, or, find more joy in the work they do. I'm happy to do that with any of my colleagues at any time.
Yeah. Well, no, I mean, I think that's a fantastic way to talk about how you got involved and really how it's benefited you. I mean, quite frankly, you mentioned, um, all the things that are going on in healthcare that from the federal and state level, from a broader vantage point, what do you think policymakers most misunderstand about rural and regional health systems that's impacting you negatively? And where do you see an out? Where do you see a glimmer of hope with respect to managing those relationships, from a legislative level?
Yeah, and I knew you'd ask me this, so I tried to give it some thought, Brendan. I certainly think that very few people that have some level of control over our industry truly understand the difficulty in providing care to the various segments of the population that we provide care to. You know, a big bulk of our business, and probably every CEO that's listening, their business is going to be governmental payers, Medicare, Medicaid beneficiaries. You know, I don't know of anybody that's making money off of those two books of business, right? And so, the government, like any other payer, wants to pay us less for the care we provide. And so, in those situations when we have to be profitable to stay open, despite being nonprofit, which makes people confused about our role in the first place. So we got to push those costs along to somebody else, right? And so I don't think, especially politicians and folks that are making laws, they don't get that. And I don't know, we go to DC, every year, sometimes multiple times a year, go to Jeff City. I'm talking to my local state rep and my local state senator. They don't have the time because they've got 20 other industries that they're dealing with in their job. They don't have the time to understand that always. Sometimes they do. And so to me, that's the challenge. How do we help them understand how thin a margin we're surviving on? And, I know they want to talk about cost, and I appreciate that. And healthcare is expensive. I'm not going to deny that either. And that cost shift that we talked about certainly comes into play. But, the cancer center I have in Hannibal now needs a new linear accelerator. I don't know what that cost specifically is going to be. It's well north of $2.5 million. Okay. I can't pay for a $2.5 million piece of equipment that delivers precise and hugely important care to a cancer patient on $25 a click. It doesn't, the math doesn't work out. Right. And so as we think about how to help folks that make decisions that impact us understand it, they have to understand that the cost issue just isn't, you get a bill from the hospital and the cost looks high to you. Everything about healthcare is expensive. And so it's going to take, to change that, we got to change it from top to bottom. Right. It's not just hospitals got to find a way to bill people less. And so until we can have those discussions and people commit the time to understanding it, I think we're going to continue to struggle with these challenges going forward. And maybe you are, I'm sure you're smarter than I am, but I'm not smart enough to figure out the answer there because it's just too big.
Yeah. Well, I took the LSAT and decided not to go to the University of Missouri. I'm not going to say whether the score was high enough to get in or whether I would have got a scholarship, but we'll leave that for the viewers to decide who's smarter and who's not. But yeah, I mean, there's a lot there, and I think the boilerplate, the takeaway there is whether there's time or not, it's all about understanding and making the time to understand and translating that into action, whether it's folks in at the Senate, at the state level, at the federal level, or even just your average person, right? You talk about the person that gets a bill who thinks, my gosh, isn't the hospital making enough money, right? Even that person needs education so that we can rise up and have a voice. But I mean, what's giving you hope? I mean, is there from that standpoint, is there anything moving in the right direction or in a direction you'd like to see that supports rural health? I mean, we've talked about the Rural Health Transformation Act, which I know we're hot and heavy. Maybe they've appointed a director to disperse some of those funds, but I'm curious what you're seeing that kind of gives you hope that's moving in a positive direction.
I think things like the Rural Health Transformation Fund are important. I think it's important that money go to rural providers, right? I think, those of us that are rural were kind of perceived to be losers out of HR1 and some of the changes to Medicare and Medicaid. And so we'll kind of see how that plays out. But I think, the place that I get a little hope is really on the advocacy side. We have, Senator Hawley that was very attuned to those things and probably was, the stimulus for that Rural Health Transformation Fund. So I think on the advocacy side, especially since some of those parts of HR1 aren't set to take place until into 27 and 28, we have time. We got to push to educate these folks on what's important to us or otherwise. But, at the end of the day, when I talk to people, I try to talk about, okay, yeah, so, I think you said something to the effect, well, doesn't the hospital make enough money? Well, for every dollar I spend, if I make $1.01, I'm generally happy, right? I'm happy on that then a margin. That's all the industries that are crying foul that work with us in providing healthcare have margins well greater than one cent on every dollar spent, right? The other thing I think about is, we talk about healthcare being 20 or 21%, whatever it is, of the GDP. Well, my healthcare is pretty important to me, right? If I need to spend 20% of, my monthly budget on getting better, I'll write that check every day of the week, right? And so, maybe it's a priorities perspective. I don't know the answer, but it certainly starts with educating and building trusting relationships with the people that we have to work with to make decisions.
Yeah. Shifting gears, I mean, from opportunities, where do you see there's threats everywhere, right? You talked about payers not paying, what it costs to actually deliver care, so unit costs not being where they need to be. And as a benefits advisor, I know that cost a lot of times gets shifted to the commercial market, right? The employer market. I see that firsthand. But I mean, what do you see as the biggest threats to financial sustainability for rural health over the next handful of years? You talk about HR1 that won't come into effect fully for a few years, but I'm curious where you would put those labels.
Yeah, I think the continued struggle in that cost shift that you talk about between, passing along losses on the governmental payer side of things to the commercial, I get it, right? If I'm the CEO of a big commercial insurance company, I don't want to cover those costs, right? I mean, there's gets into tax questions and things like that. So we'll try to stay above the fray there a little bit. But I'm really concerned personally about two areas of care for folks that don't have the advantages that you and I have, specifically Medicaid beneficiaries. I worry about them for a couple of reasons, but really the biggest one isn't how much we do or don't get paid for taking care of Medicaid beneficiaries. But if they're not able to be on the Medicaid program, they're still going to get their health care. They're going to get it in our ER, right? And that's the most expensive place for me to take care of a patient. And so when you impact the Medicaid program in ways that HR1 will, as we analyze it, you're not changing the amount of care that's provided. You're only changing, really, in a lot of ways, what setting they're going to get that care, right? Um, so I'm worried about that. I'm also worried um, from a more specific level. We're creating, because of some of these issues, we're creating maternal health deserts.
Mm,
And we hear every day about some place that is no longer going to deliver babies because it doesn't make sense.
right.
And so, sure, sometimes a mom and her husband or her partner are going to be able to drive an hour to have their baby delivered. But other times you got 10 minutes.
Right.
And so if the nearest birthing center is 40 miles away, we're going to be delivering babies in cars and everything else, right? And sure, the process is set up that sometimes that'll work, but other times it won't. And so I'm worried that we're going to be significantly changing how we take care of a lot of the patients we see on a daily basis because of these policy decisions that are made mostly in DC from a payer perspective.
Yeah. Well, there's a lot of work to be done. I mean, just talk about, outside of some of those challenges that are coming down the pike. I mean, whether they're personal, right, for you as a CEO or for the organization, what do you really think your top few strategic initiatives are heading into this year and heading into the next couple of years?
Yeah, well, and some of this is organization specific, right?
Sure.
We went live with Epic July 9th of 2025. So, we're still working hard to get through that implementation and the
That's
challenges.
not completely implemented yet. I would have figured.
Hopefully we're getting towards the end of it, but
No.
there are certainly challenges that come from that change.
Yeah.
We're looking at cost. And a lot of people think this is easy, and we hear about this a lot too. And this is, maybe my that I don't have any finance background or an MHA degree hurts me, but I don't think when you're in the growth in strategic mode that we've talked about at length in this conversation, you can't lay off people to get to a successful bottom line, right? I got to have so many people to take care of these various service lines and facilities and other places where you want to touch base. So, when salaries and benefits is, a significant part of your expense, that makes it tough. But we've got to be lean in those non-labor areas to avoid having to think about layoffs to get to a bottom line that will make us sustainable. So that we're focused on expense, but also focused on the revenue. And so we're trying to be strategic about where we're looking to add service lines, add people. Every CEO listening is going to know those services that, drive numbers to the bottom line and which don't. And so, to try to continue to do things that maybe don't drive that bottom line, I may need to do more of the ones that do. And so we're thinking about those things as an organization as well. So those are
Yeah.
kind of the big things. I do have the construction project that, I mentioned earlier. So, any, $30 million construction project has a lot of needs that have to be looked at on a daily basis. And I'm excited about that. But, it's a challenging time, but the positives are there. And so, I try not come across as too pessimistic about things in
Yeah.
healthcare, and I hope I haven't on this podcast. But there's certainly a silver lining there
Yeah.
waiting to be achieved.
Yeah. Well, you're viewing it as opportunities, right? Which any good leader would. And it's fun. I haven't had a chance with our previous guests to talk much about my experience in the professional world working with individuals and leaders like you. But right, the individuals who view benefits, the second largest line item usually for any organization, as an opportunity, right? And not as another line item that we have to figure out how to budget for, are the ones that come out ahead, right? Are the ones that are able to use it, um, and it's an asset, right? It's an asset, but they're also able to do some creative things, working together with our teams to get lean where needed to be, right? And so that's all very encouraging to hear.
Yeah, I couldn't agree more, right? I mean, um, you know, some people, some of our team members, those 1,750 people, think of benefits as, just another part of compensation, right? And so if you can, it's when you think about it strategically, then it's not just a line item on your expense sheet, right? And so I think that's important. Like I don't know about other places, but we'll help folks that want to use a high deductible health plan with the HSA attached to it. So we'll fund part of the maximum they can put into their HSA, so that they can see the benefit of that. And so it's hugely important to think about benefits in addition to everything else strategically, as opposed to just being a cost that I got to find a way to get the
Right.
cheapest thing possible. Couldn't
Right.
agree more.
Right. Well, let's talk about, I mean, again, we're wrapping up here, but and I really appreciate the conversation. Just tell me, Hannibal Regional's roots, I mean, you guys go back more than a century. How do you honor that legacy at the helm while still pushing for the organization to go forward?
Yeah, and so I love this question, because I think it's so important. We've had hospitals in Hannibal since 1902, so 124 years, give or take. Was when the first hospital in Hannibal opened up. Um, 12 or 13 years later, nuns from the Maryville, Missouri area opened up a second hospital. Now I'm old, but I'm not old enough to know what those hospitals looked like in the early 1900s, but I'm sure they're entirely different than the hospital we have now. So I always try to embrace that legacy. I talk about this with new team members. We have things on our walls that kind of talk about that history so that it doesn't go away. But you also have to be pragmatic about that too, right? Historical knowledge is always a diminishing resource. And so at some point that goes away. And so what I tell my team, and I don't force them to believe this, but it's certainly my personal perspective. I really don't think of myself personally as building a legacy here. I think of myself as serving more of a stewardship role. I've got, control, if you want to think of it that way, of this organization for a very limited period of time. At the end of the day, it's going to be less than 10% of the life to date of our organization. And so I'm going to do the best I can with that. But at the end of the day, when I'm no longer the CEO of Hannibal Regional, at some point they're not going to remember me, right? And so I try to not think of it as building a legacy, but really take it back to meeting that mission. To me, that's what's important. Okay. And so what that I think helps me do, because I think you're going to ask me to talk about a mindset shift or
Yeah.
so to me, if you think about it not as a legacy where I want people to remember the short tenure I have here fondly for 30 years, I think about it as I got to make decisions. And sometimes they got to be made quickly. Um, things are going to change. I mean, healthcare is changing almost on a weekly or a monthly basis. So the decision I make today, how that's going to be looked upon 30 years from now, it's kind of ridiculous to even try to think about trying to make a decision that would be looked favorably upon that far down the road. So, and it could be the wrong decision. I've made several, some might say many wrong decisions in my tenure, but you got to be willing to make the change or willing to make the decision, willing to embrace the change. And then if you make a decision, say, hey, I shouldn't have done it. Let's stop it and fix it and do something else. So to me, I certainly want to honor the folks that have worked here. When we talk about what I think are all the good things we've done here, that's not all on me. There's 1,750 people that work here, lots of people that served on boards and were the CEO of the organization, while I was still in diapers, right? But let's focus on doing what's good for our organization for the small time we have it under our control or we're leading it, and see where we can go with it.
Yeah. Well, I mean, you hit on the mindset question, but I mean, you're a piece of this legacy, right? And maybe you need a hall of CEO portraits so that people don't forget you, right? I don't want that. Maybe that you can institute that before. I'm just kidding, of course. But no, seriously. Before we wrap up, I mean, what is one mindset shift you believe rural healthcare leadership needs right now? And to our viewers, what's action that they can take this month to achieve that?
Yeah. Well, and I don't know about the action, but it really gets back to that embracing change. Um, we've talked about some of the things that are probably not sustainable in healthcare going forward. So we've got to do something differently. We got to think about our leadership of these organizations differently. I've done that here as we've grown the footprint of the organization, had more clinics, and employ more people than I'm sure my predecessor ever thought we would. That's a change. And if I came into it with the mindset he had 20 years ago, I probably wouldn't have done it, right? And that doesn't mean his mindset at the time was wrong, but the mindset that led an organization last year may no longer work this year.
Right.
And so if you aren't willing to change, do something differently. Tell your team that, hey, we can't just do this today the way we've always done it because that's how we've always done it. You're going to miss an opportunity. And so to me, I'd encourage my colleagues, especially those that, are newer in their roles, don't be afraid of embracing change because healthcare is going to dictate that. And the quicker you can do that and find the things that'll make your organization successful, the better off you'll be.
Right. Well, and reach out to your colleagues, right? That have embraced that change for a number of years, right? I think at the beginning of the podcast, you'd said, reach out to me, right? I mean,
Yep.
that collegial nature of getting together, sharing some of the same challenges, some of the same opportunities, is something that everyone should embrace as they keep their head on a swivel and go through this change together.
Yep. Couldn't agree more. Happy to do that anytime. And I think, probably, especially newer CEOs, probably look at a CEO like me or some of my more seasoned colleagues as just competitors. Really, there's not a lot of competition in maybe in certain areas where, and I'm blessed with some good geography up here, of course, but I don't know of any what I would call a colleague of mine that isn't willing to sit down and talk to a colleague about the struggles they're having or any of those things. And I would do that in a heartbeat. Life's too short to be struggling with whatever's causing someone a lot of stress in their job. And I'd be more than happy to help them talk through that, if that opportunity would present itself.
Yeah. Well, I appreciate you having that mindset and that willingness to connect across the aisle, so to speak, right? Todd,
Yeah.
thank you so much for hopping on, leading rural healthcare. It's been a pleasure to host you, and I know the viewers are going to really appreciate your insight.
Well, hope so. We'll see how well it turns out once you do your editing magic. But Brendan, it's been a true honor and joy to be with you today.
All right. Thank you, Todd.